I'm going to talk to you about the 1stQ AddOn secondary sulcus IOL. So this is a lens designed to go in the sulcus in pseudophakic patients. It's not a lens where we would normally put it in the sulcus for aphakia or in the bag. It's specifically designed for the sulcus. The portfolio includes monofocal toric, multifocal toric, plus a lens with a high near ad for your dry, stable AMD patients, and that's a very discrete section of patients, but that's the Charioth macular lens. It can also be used at the time of surgery, where you may decide to put two lenses in at the time rather than sometime down the track of the original cataract surgery where the patient is pseudophakic. It has 4 haptics that give it very good rotational stability, and I've never seen this lens rotate, so it's excellent for those toric corrections. It has a convex-concave design, so we don't have the legacy problems with secondary sulcus or piggyback lenses, and that was interlenticular fibrosis. And this does not occur with this lens because of the design and because of the vault. So it can be used to treat residual refractive error. So whenever we have a refractive surprise, we do a deep dive to work out what went wrong, and that may be measurement error, IOL calculation error, some kind of surgical issue on the day of surgery, or the wrong lens was implanted. So if we want to enhance these patients and bring them back to emmetropy or whatever their target was, then why not perform laser? Not everybody has access to a laser suite. You can send them to me if you want to, but I want you to also be able to do it. And unfortunately, I see a lot of patients with ocular surface disease, and unfortunately that takes a lot of chair time. So let's try and avoid operating on patients who already have dry eye or inducing further ocular surface disease with a laser. The rates in Australia, we use a lot of what we call, or what America calls, premium lenses, but worldwide the implantation of premium lenses is around 0.5%. So some patients, either it was never discussed with them, multifocality, or they had an implantation performed that was pre the toric age. I was trained in a time where there were not toric lenses freely available at the beginning of my training, so those patients do still exist, or that have just a residual refractive error.
So I spoke about this reversible option for those patients who didn't want to lose the opportunity of having cataract surgery and having good presbyopic correction. So after consenting, we offer, you're either going to get the multifocal in the bag or you're going to get it out the bag. If it's out the bag, I can reverse it very easily. There are strict anatomical requirements. You have to have normal pupil, normal zonules. You've got certain requirements for anterior chamber depth, and obviously we're not going to do it in abnormal astigmatism eyes, such as irregular astigmatism. So we looked at a comparison of 2 lenses at once, the monofocal in the bag and the sulcus multifocal add-on versus the Liberty. And for both, you have to go through this strict exclusion criteria, which is essential. And there's the story on angle alpha, kappa, tropias, issues with zonules, etc. The lens comes in a wide range. This is for a toric add-on, and that's what I've used in the post-keratoplasty patients, where I can't trust my topography data. I've got too much information across different machines, not explaining the axis adequately. Usually we've got the power right. So those are the 2 times I've used this lens quite aggressively in a planned procedure, and often as a primary event, do the one lens, do the other. So I think the loading and injecting is tricky but simple, and once you understand it, you do it yourself under the microscope. This is the insertion. This is a graft patient who's already got a lens in the bag. That is a biflex lens from Medicontur. And you remove all the viscoelastic and you treat the eyes if the operation's finished. And then when it comes to the add-on, you treat it almost like you're starting again. You selectively place your viscoelastic in 4 points to lift the iris to create the space. This is a very large lens. Do not aim it at the sulcus. Aim it into the iris plane or above. If a haptic delivers, that's fine. Otherwise, you'll rotate and deliver each haptic at a time under the iris, and you will look at this patient on the slit lamp after surgery to make sure all of 4 haptics are underneath the iris. So just a few pearls quickly. Loading technique, you put it in the cartridge. Each haptic's got to be under the ridge. When you put the plunger in forward and retract, you always must have viscoelastic between the lens and the plunger. Slow inject, angle to the iris. It's a big, big lens. It tends to try and get away from you and implant slowly. When you position one haptic at a time, I also like to do a forward and back rock, so that allows a haptic that could be curled, which will tilt the lens, to uncurl. And you check the toric position of the underlying IOL if there's a toric IOL in the bag, because you may have moved it. And then you've got to move the viscoelastic from underneath. The biggest problem is the pupil. A pre-op small pupil is a nightmare. Do not try and force it through a small pupil, because you will dislocate the lens that's in the bag. And post-op, it's ideal would have a small pupil, because then you know all the haptics are tucked. But I don't get that, because I want to look at the toric alignment and I want to make sure each haptic is under the iris, but often the iris is very well dilated. I've had one surprise where I had to go back. Good job.